सततानुशक्तान् अशेषकाय प्रसृतान् अशेषान् औत्सुक्यमोहारतिदाज्यगाञ्च यो अपूर्ववैद्याय नमोऽस्तु तस्मै. Good evening everyone who have joined us. I welcome you all for today's webinar conducted by Department of PG Studies in Shalyatantra, Government Ayurvedic Medical College, Bengaluru. I wish you all a very happy Independence Day. Today we are presenting on the topic Interpretation of MRI Spine for Disease Diagnosis in Ayurveda. And the guest speaker of this evening is Dr. Rajeshwari PN Ma'am, Associate Professor, Amrita School of Ayurveda, Kollam, Kerala. Madam currently serves as Associate Professor at the Department of Shalyatantra in Amrita School of Ayurveda, Kerala. Having received her BAMS degree from Alvas Ayurvedic Medical College, Mudbidri in 2007, Ma'am has completed her Masters in Shalyatantra from our own Government Ayurvedic Medical College, Bengaluru in 2010. Madam has also pursued her PhD in Shalyatantra from National Institute of Ayurveda, Jaipur, Rajasthan in the year 2014. She has authored and co-authored more than 30 national and international publications, guided nearly 50 oral presentations of postgraduate scholars. She is now into the new drug development in Ayurveda for urinary diseases and acid peptic diseases. Ma'am has conducted extensive research on acute medicines on peptic ulcer, urinary tract infection, inflammatory markers like IL-6, CRP, wound healing, and has also presented the papers in international traditional and complementary medicine conferences held at Osaka, Japan, and Dubai, UAE. It's our pleasure that you are with us today, ma'am.
Thank you, Doctor.
May I now request Dr. Srinivas Maslekar, Sir, Associate Professor, Department of Shalyatantra, GMC, Bengaluru, to welcome our guest speaker and all our audience.
Thank you, Archana. Thank you, Archana.
Thank you, sir.
Good evening, everyone. Good evening, Rajeshwari Madam. Yeah, it's our pleasure to have you on the webinar today. And Rajeshwari Madam happens to be my junior and one of my close friends, and I'm really overwhelmed to see her very nice profile. Okay, so I welcome Dr. Rajeshwari to the webinar from on behalf of Principal, Department of Shalyatantra PG Studies, GMC Bangalore, and all UG students and PG scholars of Shalyatantra Department. So I welcome you, Madam, and I just want you to continue with the webinar. So let us have a very good, informative, knowledgeable session to all our PG scholars and final year students. Thank you so much, Madam. Please continue.
Thank you, sir. Thank you, sir. It's my privilege.
Thank you for the welcome note, sir. Just a little instruction to our audience. Kindly mute yourself during the session. If you have any queries or doubts during the presentation, please type them into the question box. We will bring them up at the end of the session. Thank you. Now, without further ado, we will turn the time over to our guest speaker, Dr. Rajeshwari ma'am. Over to you, ma'am.
Thank you. Slides are visible, right?
Yes, ma'am, it's visible, ma'am.
Okay, thank you. Good evening, everyone. It's my pleasure and it's my honor to speak in front of my teachers and also my own postgraduate institution. And today I'm in front of you with a new topic, that is interpretation of MRI spine for diseases and diagnosis in Ayurveda. How MRI spine can help in the disease diagnosis and how we can plan our treatment is my motto of presentation. And with the background, I just move with my slides. That is, we know that in Ayurveda, the spine diseases and management will be coming under Vatavyadi and its treatment. So we don't have any specific set of treatment principles we follow. Instead, we will be going in the general treatment principles of Vatavyadi. So all these diseases we consider under Asti Vikaras, and Vata dosha is the Ashraya which is taking place in Asti Dhatu, and hence Vatahara treatments are Vata Prakopakari Danas and it's breaking the Samprapti is a treatment module which we oftenly follow. So in my presentation, let's discuss how MRI spine can help us for proper diagnosis or getting into the appropriate diagnosis, and how it helps us to plan treatment which is most successful, and also it can give relief to the patients in a short span of time period. Uh, Let me continue with a small introduction. As we all know, a MRI is an imaging technique where magnetic field and computer generated radio waves are used, and this will give a detailed picture of organs or tissues. And in the MRI spine, it includes almost all the details of bones, soft tissues, spinal cord, nerves, and also even the intervertebral disc. And hence, it is considered as the gold standard diagnostic tool for diagnosing the diseases of spine. And moving to the presentations, before I interpret few of the reports, let us know what are the anatomical landmarks that we often come across in the MRI reports. Because always every of my students will tell that there is a lot of terminologies which will be feeling like it's quite complicated or quite tough to interpret, and we will be in a confusion whether our interpretation is right or whether the diagnosis is right, how to convince the patient, how to convince ourselves so that we can plan a good treatment. All these questions will be arising when we look into the MRI reports. So before going to the interpretation, let us see what are the landmarks which will be often repeated in the reports. So we know that in the spine we have few important uh, names and also few important bony landmarks which will be giving a more idea related to the functioning of that particular part or pathology related to that part, and so on. The questions will be asked, or the what comments will be given based on the anatomical landmarks. So let me go with the C1, that is Atlas. We call it as a with a special name, that is Atlas. The second C, that is cervical vertebrae, we will call it as an axis. Now, in these two bones, no need to go in detail with the structures. Instead, we have to remember an overall anatomy where most often repeated terminologies. For example, in this I have mentioned articular facets. This is articular facet for dense in case of C1, and also in the C2 we can go for this articular facets for the atlas. This is also another landmark which we are going to get, and transverse foramens. These terms you please do remember before I just discuss the reports, because more and more times we'll get the same terminologies repeating in the reports. So these are the basic informations. We have 33 spine vertebrae, and in that cervical, it is classified into thoracic, lumbar, and sacral, and also the last is a coccyx. So once again, I'll be dealing with the same two bones, that is atlas and axis. You can just look into the arrow, blue arrow, which is highlighting the transverse ligament. And this transverse ligament, in the first picture, there is a transverse ligament of atlas is given. So this is very important for the movement of atlantoaxial joints. So it is going to give a kind of a smaller degree of movements to the bones, that is atlas and the axis. And we have to remember here, whenever there is an injury occurs to the these particular part, the flexion or the lateral rotations or lateral movements of the neck will be hampered. In the same way, I have marked in a yellow color, that is bifid spinous process. This is a normal part of axis bone where the spinous process is bifid here. It is not an anomaly. Instead, it is for ligamentum nuchae, which will be passing there, so that all these intervertebral spaces are held together, and it is going to give attachment to few muscles, and because it doesn't have a larger body, this bifid spinous process will serve the purpose. So this will be a normal presentation in case of C2. When you look into the X-ray, you no need to get confused. This is a normal bifid spinous process. And the first picture, the most important landmark was transverse ligament of the atlas. Now, let's move to the little explanation I'll give related to the transverse ligament. So, on the red arrow, I have highlighted the transverse ligament, and this there is a dens which is or a odontoid process which is acting like a pivot there. So the ligament is enabling two kinds of movements. Like when you say yes and shake your head, then also it works. When you say the movements like no, when you are laterally moving your heads at the time also, this particular joint and the ligament is giving a rotatory actions. So this will be a normal in a patient. And there are conditions where there is a rupture of transverse ligament, and it is causing subluxation of the atlantoaxial joints, or it can even occur in the fracture of atlas. So this is a brief introductions. So when we come to the thoracic vertebra, we have a body of thoracic vertebrae which is quite larger, and it is considered to be the most stable among the vertebrae because it is not so much mobile, and there are articular facets which is connected to the adjacent vertebrae, and in the center we have a vertebral foramen where the spinal cord passes, and we have the superior costal facets, means the facets which attaches to the ribs. And you can just look into the lateral view, the spinous process, there is no any bifid, or it is not any there is no any bifid appearance of the spinous process. So this is about that. Then we will, when we look into the lumbar vertebrae, the body is quite large, and it is a weight bearing part, and it will be bearing the whole body weight of the person, and it gives a maximum movement, and that is the flexibility is more. Along with that, it is having more prone for, it's a tendency for injuries also. So with that view, when we see the structures look similar, it has a body, vertebral foramen is also there, then we have a spinous process is also there, and articular surfaces or articular notches are also present here. So with these brief introductions, let's move into the pathology, how it looks. So in the cervical spine, I told that there is a spine is bifid and it is normal. But when it comes to the lower spines, lower levels, that is lumbosacral levels or in the lumbar region, if you are getting a spina bifida occulta. So this is a kind of anomaly, and this doesn't cause much of the symptoms. It is a clinically insignificant condition. When this X-ray was taken for a patient who had a fracture in the shaft of femur, and he had some the pain in the low back leg. So this was a accidental diagnosis of spina bifida occulta. In the marked area, you can just see there is the spinous process is not joined together. There is some kind of bifurcations. This is clinically insignificant. Even the patient did not have any tenderness over that area, and it was not at all known to him until this X-ray was taken. So when we read about this disease, most of the patients it becomes a clinically insignificant conditions. So let's come into the topic proper. In the spine and the diseases, the most important structure we come across is the intervertebral discs. So these intervertebral discs are lying adjacent to the vertebrae in the vertebral column, and they act as a shock absorbers and what all the jerky movements a person will be handling, all those movements and its pressure is borne by this intervertebral disc. And it is intervertebral disc is in this picture you can see that it is having the blue and pink, the surface is called as this part is the intervertebral disc. So intervertebral disc has two components. I'll give just a small introduction here. It has two components. The one is the outer component and one is the inner component. So outer component we call it as annulus fibrosus. This is a fibrous band. Whereas the inner part is nucleus pulposus. This nucleus pulposus is like a jelly-like material which is embedded inside one fibrous disc, and it is acting as a shock absorber. That fluid or a jelly-like substance is acting as a shock absorber. So that's why it maintains the uh, maximum pressure or maximum pain thresholds which occurs accidentally, or it may be unknowingly the patient may fall, but at one in the beginning he may not feel much pain because that pressure exerted to that part is partially taken up by this intervertebral disc. So the patient will be fine. After some times that pain will go off, and most of the time he may not suffer from any major trauma. Once the threshold is crossed, threshold means there is a capacity for this disc to withhold a kind of injury or a trauma or pressure. Once this has been crossed beyond its threshold, then there will be chances of injury to this intervertebral disc. This is one set of etiology, that is traumatic. Another one is this particular structure is devoid of blood supply. This is a avascular tissue, and it is supplied by the diffusion or osmosis which is taking place near to this intervertebral disc, that is paraspinal spaces. And in this point, apart from traumatic, when it is coming to the nutritional deficiency, we have the broader understanding of the nutritional deficiency in our science, or something is decreasing in volume. We call it as kshaya. And this kshaya is not something related to a major disease. Here we are discussing about the vata. So the function of vata is getting increased because all these disturbances is caused by the vata. So the main treatment principle of selecting vata dosha in our treatment begins here. So we have to, let's go hand in hand with the clinical applications and diagnostic approach also, so that you'll be very happy to understand that this is how it works. Okay. So this is about the intervertebral disc. So this is how a normal or a healthy cervical disc looks. It has a nucleus inside and annulus fibrosus outside. We have a nerve root which passes on the sides, that is bilateral neural foramens are there, where spinal nerve passes, and the central canal there is a passage of the spinal cord. And here there is the complete structure is normal. There is no any pressure exerted. There is no any trauma. All are functioning in a smoother way. Even in the lumbar disc space also, the normal disc is compact and it is not showing any of the abnormalities. Please keep these pictures in your mind, and it will help you to compare with the anomalies. Now, from here, I'll start with the pathologies along with the normal few terminologies also. Make a picture of this particular slide in your brain, saying that there is a normal curvatures of spine. That is, cervical spine is also have a curvature, normal curvature. Thoracic is also having a normal curvature. Lumbar is also having a normal curvature, and even sacrococcygeal is also having the normal curvatures. But cervical, thoracic, and lumbar, these curvatures are quite important or more important when we are assessing the pathologies. See, in the normal, cervical spine has a shape. We call it as lordosis. This is a normal curvature of spine. Cervical lordosis, thoracic kyphosis, and lumbar lordosis. So this is the normal appearance or the normal curvatures of spine which is present in a healthy individuals. For example, first clinical condition which we get related to this spine pathologies is scoliosis. So you can see in this picture, the scoliosis is it's a condition where the spine curves to either to the left or a right. It may not be only one side. We call it as a right deviation or left deviation of the spine. And this deviation can form in the shape of S or C. If it is S, okay, the curvature is not much distorted. When it becomes C, the curvature is much more distorted. This is what the understanding. Even this you can diagnose along with the in the clinical examination itself and also through X-ray. No need of MRI here, but still few patients when the left deviation or right deviation is very minimal, they may not observe in their day-to-day life. Instead, what will be there? The patient or the person will be always complaining of a kind of discomfort during the postural changes or when he travels for a long time and if he is sitting for a long time. All these conditions can trigger a kind of pain to this patient if the degree of deviation is very minimum. So when it is only a S shape, he or she may not complain or he may not come to the doctor itself. And most of the times when the young adults, when we are taking a X-ray, we can see some partial deviation that is towards the left or right. This is also a cause for low back pain, a kind of lumbago. Coming to the reports, you can see when we get a report, I have highlighted few points only, but the points which are very much essential to discuss here, I have highlighted, and you can concentrate on those points itself. And in this particular MRI report, there is scoliosis of spine with primary convexity of thoracic spine towards right. It is a right deviation. And secondary compensatory convexity of lumbar spine towards left. So when we are students of surgery or Shalyatantra, when we study some of the pathologies, we get a common term that is compensatory hypertrophy or compensatory inflammations or compensatory convexity changes or angular changes. Why this happens is one part is not working properly. It has lost or it is showing some distortions in its functions or in its anatomical positions, and hence there is a kind of pressure or a trauma is happening to the neighboring structures or nearby structures or even adjacent structures. So here in this report also they are highlighting the patient is having scoliosis of spine with primary convexity of thoracic spine towards right. Not too much worry about this term. As a beginner, you can understand it is in a simple way. The thoracic spine is towards right, means it is a right deviation, and secondary compensatory convexity of lumbar spine towards left. So because of this change in the shape, in of the thoracic spine, even the lumbar spine is suffering. So what is happening? The compensatory pressure is it's observed even on the lumbar spine, and there is a small deviation or there is a small changes in the normal curvature of the lumbar spine also. So now we have understood what is the mechanism which is causing problems or which is causing trouble to the patients, if it is a low back pain or if it is some kind of only a postural discomfort he is having. Now you can assess. Now you know the picture of the disease, how it is presented in the patient, and now we can plan what can be given. So if it's related, if the degree is, you can examine the patient in the clinical examinations. You can get it how to examine a scoliosis patient. You can even examine clinically and look for the deviation, if it whether it is minimum or maximum, and you plan whether you should give any conservative treatments. Along with, you have to give physiotherapy. So this exercise, that's how the approach of our approach to this particular patient is changing when we are understanding the uh, what the exact situation or exact pathological conditions. Otherwise, he may or she may come to you and tell it is a low back pain, and we'll give, or anyone will give a kind of what painkillers or some medicines which are related to the nerve strengthening, whatever we'll be giving to that. But the purpose is not served here until the diagnosis is done properly. If you doesn't give any physiotherapy here, or if you are not advising some kind of exercises, the patient may not get a long-term benefits. It may be a symptomatic relief, and the symptoms can come back after a short span of time. Okay, now let's move to the next report. So I told in the beginning, there is normal curvature of the C spine is lordosis. Now we have a terminology. In this slide, we have two terminologies. One is loss of cervical lordosis, and the second one is the highlighted in a blue line, that is, there is reversal of cervical lordosis. See, loss of cervical lordosis will be given in certain reports, and also there is reversal of cervical lordosis is also given in some of the reports. No need to get confused. Both are same. Both the terminologies are similar. They are telling us normal lordosis of C spine is lost. That's the first word. There is reversal of cervical lordosis. The reversal, it is the opposite of cervical lordosis, means it might have happened with cervical kyphosis. That's why the patient comes to you with these two reports with these two terminologies. No need to get any confusions. Both are same. So there are a lot of reasons which will be causing loss of cervical lordosis. Now, your exact clinical examination begins here. Why this has caused the cervical lordosis? What is the reason? Whether patient is having any rheumatic diseases, whether he is having any early degenerative changes, whether he is having any secondary osteoarthritis, whether this patient is a known case of ankylosing spondylitis, means a stiff spine that we call it as a bamboo spine, whether such conditions are there. So you need to rule out what are the primary causes and what are the secondary causes. Even the commonest presentation in the loss of cervical lordosis or reversal of cervical lordosis will be a stiffness, and there is a restricted range of movements. Now, when you examine on all those backgrounds what we have discussed, but nothing is found, it has nothing is positive, no any reports are positive. At the time, what we will do? At the time, we need to understand that even the paraspinal muscular spasms, paraspinal muscle spasms means the both the sides of spine we have the muscles, and these muscles, when they are stiff, or when the muscle stiffness happens in a patient, what we call in all this mamsabhata vata avarana, all those mechanisms we can bring into that. At that situation also, or any long-term trauma, patient is taking medicines from long time, he has a low backache, but it was not any nothing to do with intervertebral disc or bones. It was a muscle spasm which had caused in the beginning, but he has not taken treatment properly. Now what happens? Instead of muscle relaxation, the muscle over a time period it has become stiff, And when something is pulling, and the curvature of spine is also pulled along with that, because all these cervical vertebrae or lumbar vertebrae, thoracic, is working in coordination with these paraspinal muscles. So whenever it pulls, there is change in the cervical lordosis. So this identification is must before we start our treatment. If it is a muscle spasm, nothing to do with any other medications, you have to go for external therapies so that it relieves the muscle spasm. Once the muscle spasm is relieved, the patient automatically gets relieved from the pain. So this is one clinical informations. Okay, this is another report. So along with that, one more word is being given: loss of cervical lordosis with straightening of spine. As I explained, when the muscle is pulling these uh, spine, that is C spine or lumbar spine, the curvature will be lost. Instead, the spine looks straight. Instead, the spine looks straight. So that's why they are giving the name as straightening of spine. And it's most commonly occurring clinical conditions in young or in persons who are within the age group of, that is fourth decade of life, 40 years, within 40 years, or within 20 years. Even sports related persons are also getting this kind of issues. Here, when you do all the low back examinations, or the cervical examinations related to the nerve compression, everything will be normal. You don't get anything related to the SLR or even annual test, nothing. All these tests will be negative, but patient has a pain and he is not happy with our treatment, and he oftenly visits and telling that the pain has not been reduced. So once we release this muscle spasm, automatically the pain also releases. And also when we give some of the therapies, along with that we need a physiotherapist help is a must here to give pain relieving and also muscle relaxing treatments. And of course all our medications which is helping in relieving the stiffness, pain, and also inflammation. Everything can be given here based on the locations. You can select the drug. If it is a cervical, the set of medicines can change. If it is a lumbar, the set of medicines can be changed. And this is how we can treat. And once the diagnosis is fine or it's very correct, no doubt the patient will be fine in 5 days, 10 days, or even within a week, he or she will be fine with this situation. In the sense, 70 to 80% of all the symptoms will get relieved when we are intervening in a right way, and also if you are targeting that particular pathologies. Now let's come to the lumbar lordosis. This is also similar to the condition of cervical lordosis. See, loss of normal lumbar lordosis, because the report itself saying normal lumbar lordosis is lost, and as all the points what we discussed is explained here, possibly due to a muscle spasm. All other things will become secondary. This particular problem, you can see the chronological order of the impressions given by the radiologist, which is the most disturbing point here. It may not be disc issues, desiccations, degenerative changes. What is the most concerned point? That is all. The chronological order of the impression also says how this um, how the radiologist is addressing this particular disease. So the first point he is here he is giving loss of normal lordosis, possibly due to muscle spasm. So the muscle spasm is the main culprit, which is causing a lot of issues, a lot of problems to this particular patient, and we have to address this problem at the earliest. So this is also a clue for our diagnosis. Okay. I have again few more reports. Once again, there is a loss of lumbar lordosis. Okay. With that information, so I have explained the conditions related to the curvatures, normal curvatures of the spine, how it is lost, what are the probable causes which is going to cause this deviations from the normal curvatures of the spine. So that those are all the basic informations we can understand or we can get when we go through a report. Now we'll come to the most important and the core point of this MRI reading related to the C spine or lumbar spine. Every time when we read and every time when we are interpreting the reports, these terms will be oftenly present in the report, and we don't know how it is important, why it is so much, why they are repeatedly explained in the reports. We may be getting astonished when you are in a final year student or in an internship, when you are into this kind of exposures. We'll say that, and at one point we'll feel that all these are same. Why the specification is written in the L4, L5, L1, L2, L3, and L4, L5? Why? They could have written in the whole lumbar vertebrae, but it has something uh, very important, and let's discuss how beautifully we can treat based on these reports. I don't think that these reports preparing these MRI reports or advising the MRI reports to a patient is not always required. It's not so. Most of the times we think that prescription is given by us is not giving much relief to the patient, means we will be having a doubt on the medications whether they are manufactured properly or not. This is a common, when we were student also the same question used to arise. But what we experience after all these years is, even though medicines are correct or the good company medicines you are prescribing, all the fellowship of the drugs, but if you are not selecting that particular clinical condition, then those medicines won't work. Instead, the patient will be disturbing us, always telling that, doctor, you had given this medicines, it's not giving any kind of relief. So this problem will be, it will be a challenge to the clinicians. So let's make an uh, simplified form of all these impressions, that is MRI impressions, and we can interpret them and we can understand them and we can give our best treatment for all these clinical treatments. Okay, coming to the term disc desiccation. See, the word disc desiccation, disc is referring to the intervertebral disc. The right side, first is one MRI picture I have put. The second part is analogous for this. This is disc desiccation. Disc desiccation means there is a complete degeneration of this particular intervertebral disc, and it is looking like a barren land. The surfaces of the intervertebral disc is looking like a barren land, means it is extremely dehydrated state. I told this intervertebral disc doesn't have a blood supply. Instead, they are getting nutrition from the neighboring tissues in the form of osmosis or diffusions. Now, when a person is not indulging in these, the proper nutritional conditions or proper nourishment to his body, then the problem arises. This is very tough to explain in a more contemporary system of medicine, how nutritional deficiency can happen. But we know in Ayurveda we have, whenever we are not taking care of our body, it is obviously Ruksha Aharas, Viharas is going to cause a Vata Prakopa. So whenever you get a report saying that this desiccation, it absolutely says, you can interrogate with the patient, it absolutely says the patient is indulging in all Vatala, Aharas and Viharas. You can just simply ask him what is his occupation. He may tell that he is traveling every day for about 50 to 60 kilometers or more than that. So this is the first impression what we get. This is a Vatakara Nidanas. Okay, in the same way we have to interpret here. Let's come to the point. Disc desiccation, it's the most commonest terminologies we get, and here it is a dehydration. It refers to the devoid of water contents in the intervertebral disc. So that is the understanding here. And we know that it is the intervertebral disc is having a jelly-like substance or a fluid-rich structure. And as the age progresses, when the person is old age related to his fifth or sixth decade of life, or even if he is indulging in all these vatakara, haras, and viharas. This is how we have to interpret here. Then the patient will suffer from early degenerative changes. Early degenerative changes. And all these early degenerative changes, if it is present in a person and he has not taken care of it, and he is continuing his day-to-day activities, he is not at all bothered about his health, this condition can happen in the early 20s or even 30s. And that's why we can see a lot of patients who are within the year 30 years of age are suffering from this disc desiccation. Okay, so in this, when we see into the reports, we'll get you just concentrate on the highlighted points. First observation is loss of lumbar lordosis with straightening of spine, mild straightening of spine is there. Early marginal osteophytes noted at L2, L3, L4 vertebral bodies. It says vertebral bodies of lumbar vertebrae starting from L2 to L4 are having marginal osteophytes, but it is early. Early means the patient is suffering from early osteoarthritis. Next, below I have told about all these conditions or observations are suggestive of disc desiccation. So it is also a type of degenerative disc disease where extreme dryness of the disc happens here. And hence, the normal compactness of this intervertebral disc will be lost, and no need of any trauma in this condition. The patient all of a sudden will suffer from low backache, and if you are going, if in that age, we will be always asking about the trauma, whether he went for play, everything and all, but nothing such histories will be there. And when you see him, if you are observing correctly the prakriti of the patient, he may be a vata pradhana prakriti person will be there. Okay, and all these will be suggestive of disc desiccation. Now, how we have to treat, it is also a big question, because this is a degenerative disease, and once again all the treatment principles of Vatavyadi comes here, and yes, is the taradhama of dosha, which dosha is highly prominent, which is the next one, which is the third one. So like this, you can, based on the interrogation with the patient, you can plan the treatments. And there is no doubt here, there is no avarana here, it is purely a dhatu kshayaja vikara. Directly you can go for the treatments which are told for dhatu kshaya, and that is taken from Vatavyadi Chikitsa. Next, let's come to the word disc herniation. So this is a it is also another most important terminology which we are oftenly getting in the reports. Before that, let's see the second picture in the in the top row. That is, sorry, right hand first one. That is the nucleus pulposus is there. Disc annular ligaments is also there. You have a nerve root, neural foramen, spinal cord, absolutely healthy. See, come to the next stage, that is 4 stages to a disc herniation. Whenever I take up this class, I'll give you always my students an example of a candy which is stuffed inside some kind of jelly-like material. You can imagine a candy which is having a gel inside. So the outer covering will be a little bit harder. Inner you will have a soft jelly-like substance. So what is this? Degeneration. So that complete chocolate, you can just take it and you just open it and keep it outside for some minutes. You know, the outer layer starts to melt. And when you press it, when it is melting, when you press it, the consistency is not as hard as before you are taken from the particular wrapper. Is it not? In the same way, the consistency has started to become soft because it has lost its compactness. In the same way, in the first stage of disc degeneration, the compactness of the outer layer, that is annulus fibrosis, is going to begin to decrease. The compactness in the outer layer, when it begins to happen, the nucleus pulposus also loses its capacity. That is because it is tightly embedded there. Instead, it starts to become a little bit relaxed. So this is also a danger. In this stage itself, the patient becomes quite susceptible for the injuries. Next stage, you can see prolapse. You can see the prolapse. The annulus fibrosis outer covering has lost its little more compactness, but it has not torn. It has not torn. Annulus fibrosis is not torn, but nucleus pulposus has become quite liquid. Means the fluidity has lost its compactness, but it is started to move from its normal compact location to the uh, towards the injured side or the most vulnerable side. The third picture, you can see extrusion. The disc annulus fibrosis has been torn. It has lost its compactness, and the nucleus pulposus started to come out. So this is the third stage. Fourth is a sequestration. You can see in the fourth stage, all the structures, that is annulus fibrosis, nucleus pulposus, and even the vertebral bodies, that is vertebral end plates, we call it as, and these are all damaged. And this is a stage of sequestration. Let me say a few clinical points here. When we are discussing about degeneration, prolapse or extrusion is also known as herniation. These three stages are easy to treat. That is, especially first and second stages, quite easy to treat. Patient will becomes absolutely normal after the injury in most of the cases. And extrusion is quite tough to treat. Patient may get the symptoms after 6 months. The sequestrations, we have to think before we are choosing the treatments. Okay. Coming to this particular the upper picture, intervertebral disc herniation. The intervertebral disc herniation has happened. The nucleus pulposus uh, is oozing. In the annulus fibrosis has lost its compactness. See what it is doing? It is pinching the nerve, means irritating the nerve. It has a normal, it has to stay in a normal space so that it will not disturb the neighbors. The distance has to be maintained, but it has lost the distance. It has coming and it is giving some friction to the neighboring structures. Now, in this stage, the patient starts to experience pain. That is, whenever degeneration happens, whenever prolapse happens, this is the reason why patient is getting pain. That is, it has a normal compartment where he has to stay. That intervertebral disc has to stay in that particular compartment. He should not come and disturb the others. But once its diameter changes, then at the time it starts to hurt or irritate the neighboring structures. So other structures are bone, and spinal cord is inside the bony cavity. It's not hurt, it's not getting any disturbances very fast. Instead, the spinal nerves which are emerging out on both the sides, you can see in the first picture, on the both sides there is a nerve root, and it is going to cause the irritations. And that's why all the diseases are causing pain to the patients. In the last picture, you can see in the MRI imaging, there is an arrow is being shown where that black part is the herniated disc. Okay, So that is coming and it is giving some pushing towards the, or it's giving a kind of irritation to the spinal cord. So that we call it as disc herniation. And this disc herniation will show all the clinical features related to the radiculopathy, that is nerve related pains. Next, in the report, we get, see, you can just look into the impression, minimum posterior bulge of annulus fibrosis at L4, L5 level. So it says which annulus fibrosis is disturbed. It's only a bulge, so nothing to worry about it. You can just plan the treatment and the patient can get a good prognosis. See, you can see here disc bulge. I have not marked the first point, that's lumbar spondylosis. We can discuss later. It is a case of degenerative changes. See, in the second point, mild degenerative disc changes involving L2, L3, L3, L4, L4, L5 intervertebral disc. This is the reason why they'll give set of all the intervertebral names why L1 is told, because they are mentioning the degenerative disc changes is happening in intervertebral disc presenting in between L2, L3, in between L3 and L4, in between L4 and L5 intervertebral disc. That is why in the report you'll get all the names of the vertebrae. Next, in the third point, there is a diffuse disc bulge. So overall, what this report is telling is about the disc herniation has not occurred. The condition is early osteoarthritic changes has begun in the patient and it has started, it has begun to show some of the clinical symptoms in the form of disc bulge. So if you are informing this to the patient, if we are changing his lifestyle along with the medicine and treatment, then of course all these conditions can be taken back to some extent. Whatever the degenerative changes that has happened already cannot be reversed in most of the cases. Instead, we can arrest the progress of conditions. So all these will give you a idea of how you have to select your prescription. Early degenerative changes in a young patient means you have to be a little bit more cautious in explaining the diet and regimens also, because those two factors are causing more of degenerative changes rather than his body or rather than his age. Okay, so it's not a natural mechanism, it's an induced mechanism which is happening in his body, and you have to restrict or you have to cut that particular etiology which is causing this this clinical presentation. That's why your prescription depends on the impressions given in this particular MRI reports. Next. One more important observation what we get in case of low back pain is oftenly in the reports we get ligamentum flavum hypertrophy. So we know that this ligamentum flavum is elastic tissue which is running from axis to the sacrum. So it is the most the widely connected part of the ligament which is present from the C1 to the even up to the sacrum. And these bands will be serving as a covering to the spinal canal and also it supports. But when this ligamentum flavum hypertrophy occurs, ligamentum flavum hypertrophy means, for example, patient as a weightlifter, he has lifted a heavy weight and during that process, he felt some pain in the low back region. And he has over 2 or 3 days, the pain has relieved. Once again, he is into the same job or a heavy worker, daily wages worker also. He also lifting the weights from longer durations and this will happen. But it's not much problematic to the patient and hence he or she may not come to the doctor. Now, over a time period, this particular muscular injury can lead into a hypertrophy. You know, the muscle will be expanding, expanding and expanding and when it crosses its normal threshold, then the hypertrophic changes will happen. Okay, so this ligamentum flavum hypertrophy is not a pathological condition as such, but it has one side effect because it causes um, hypertrophy is always causing a kind of lumbar canal stenosis. Means that is the spinal canal, which is having, because it covers the spinal cord and it protects the spinal cord also. So in that space, when it is hypertrophied and present, it is going to give some informations or some messages, pinching like messages to the spinal cord. So the patient will experience the pain, and that's the reason when when it is not showing any radicular issues, in the sense the radiculopathy or a nerve pain, radiating type of pain is not in a patient, but ligamentum flavum hypertrophy is there, then you can give them a information. So this is what it happens. The yellow color is a the arcuate line is called as the uh, ligamentum flavum. It has hypertrophied and it is giving some pressure, or it is narrowing the canal of spinal cord, and hence there may be a chances of nerve pinching. Nerve irritation, we call it as in the MRI language, it is called as pinching of nerves. So this will lead to a symptom. So this awareness you can give to the patient. So it's already this part is damaged. No need to give much of pressure or workload on that particular structure. Instead, take care so that your problem will be solved automatically. Once that etiological factor is withdrawn, the progression of this ligamentum flavum hypertrophy decreases, and that's why this information can be conveyed to the patient. Now, another point is facet joint arthropathy. In the beginning, I have shown some articular facets. It may be costal articular facets in this thoracic part, or it may be intervertebral facet joints. So intervertebral facet joints also contain a cartilaginous tissues. So whenever a patient suffers from osteoarthritis, these cartilages also can get damaged and person gets a early osteoarthritic changes or a complete manifestation of osteoarthritis. So he will be having tenderness over those facet joints, and the whole of the spine will be painful, or even the cervical, if it is restricted to cervical, the cervical pain may be there. If it is restricted to the lumbar, the pain may be in the lumbar region also will be present. So this is also an observation given in the MRI reports. So facet joint arthropathy, if you get, we can understand that the cartilaginous joints of intervertebral discs are also damaged if it is in the lumbar or in the cervical. If it is in the thoracic, we have to think about the costal articular facets which are being damaged. That is the part which is attaching to the ribs. So this is a report which says that suggestive of degenerative disc disease. And in the second point, we have bilateral facet joint arthrosis. So here arthrosis is a clinical condition where facet joint is being involved. So that's a broader sense. And the relating point is it is suggestive of degenerative disc diseases. And overall, a patient is having a degenerative conditions in the body, and hence multiple joints has been affected, and one among those is the facet joints of the vertebrae. So next term what we get in a MRI report is a neural foramen. It is it's a intervertebral foramen. You have studied in anatomy, there is a small hole through which the spinal nerves will exit, and this neural foramen narrowing is a clinical conditions explained in MRI reports. Neural foramen narrowing means you can see in the first picture and also in the second picture. The reddish part is a narrowing. The second right side, the picture, the first is related to the uh, the spinal canal narrowing. This spinal canal narrowing on and neural foramen narrowing is also is secondary to the osteoarthritis. Why it happens is because of the presence of osteophytes. You know that whenever there is a degenerative changes occurs in the bones, the osteophytes are formed. So similarly, the osteophytes are formed even in the neural foramen and also over the intervertebral foramen. So what it does, it completely irritates this particular spinal cord and also the exiting nerve roots. So it's like a channel. Now, I will always explain like a channel where the intervertebral foramen is present and the nerve is passing. So the channel is smooth in the beginning, but and it is not causing any disturbance or irritation to the nerve. But whenever there is osteophyte formations, you imagine there are some spikes and in the channel there is a spikes and these spikes will be always irritating the nerves and hence patient will get a pain. So whenever you get a report telling that disc degeneration, dehydration, loss of lumbar, lordosis, whatever, all those points whatever discussed, along with that neural foramen stenosis or narrowing of intervertebral foramens, then we have to think and explain to the patient regarding the prognosis because osteophytes are formed and we cannot reverse that particular condition and hence we can give the best treatments as per the patient's requirement but the probable success rate may be only around 60 to 70%. So this has to be conveyed to the patient because there is some kind of structural anomaly has been occurred and that nerve always gets irritated by this osteophyte. So you cannot escape from that. And that's why we have to understand that particular clinical mechanism and we have to be open with the patients telling that this condition can only be managed. In the sense, we can give a kind of a relief for about 50 to 60%. You can just, I'll say only 50% in the beginning. If patient gets 70%, he is very happy. If 50% is also, he is somewhat convinced. So this prognosis explanation to the patient is very much essential. So in the reports we can get, I can see there highlighted part, it is bilateral neural foraminal compromise. Narrowing and compromise both are similar. In few reports there will be a narrowing, it will be written, and in few reports there is a compromise word will be given. Both are similar. Now, most repeated terms everyone will be hearing and everyone will write the diagnosis of spondylosis, spondylitis, spondylolisthesis, and so what exactly is the mechanism? See the picture, you can see the upper one where intervertebral disc and the surface of vertebral body is smooth. There is no any damage. See in the second picture, in where arrow I have shown with an arrow mark, you have some ridges over the vertebral body. So this is called as end plate changes. So these upper end plate and lower end plate changes. And these end plate changes are the indications of degenerative diseases. You can see the disc size also. The size of the intervertebral disc is reduced. And the first and the above intervertebral disc, the size is normal and these end plates are also normal. So the spondylosis word uh, in general says about it is the degenerative changes which is happening which, in the form of even spur formations or a degeneration of the intervertebral discs. All these words which is occurring because of the degeneration, we call it or we put it in a single word called as spondylosis. Okay. Next is you can see in this report, lumbar spondylosis is present and mild degenerative disc changes involving L2, L3. Means disc changes are there in the intervertebral disc, which is present below the L2 and L3, L3 and L4, and L4 and L5 intervertebral disc. So patient is having the involvement of 2 or 3 intervertebral disc, and it is in total the first impression, that is as I told in a chronological order, the most importance is given for the first impression, that is lumbar spondylosis. This is a for diagnosis what they are giving. All others, if you read in detail, all the disease, all the impressions are telling something related to the degenerative changes. Next is a spondylolisthesis. Slides are visible. Okay. Spondylolisthesis, and spondylolisthesis occurs when one vertebra slips forward over the other one, which is just below to that. You can see in the picture. There is in the arrow mark, we have vertebra upper one, L4 is there, L5 is displaced from its normal position. So this one we are calling it as the spondylolisthesis. Listhesis means there should be a displacement, and this displaced vertebral body causes damage or injury to the nearby structures, especially here related to the spinal cord. Next is a spondylolisthesis. This is the word we have, spondylolisthesis, and in the impression you can see that pseudolisthesis of L4 over L5 anteriorly with vacuum phenomena. What is this vacuum phenomena? We'll discuss later. And you see the two impressions saying suggestive of degenerative disc disease. Okay, let's come to the word what we have discussed, that is pseudo-spondylolisthesis. See, when we are looking into the L4, L5 and S1 in that level, we have two structures we have to remember. That is the pars interarticularis. So this is a thin arch of bone, and which is present at the level of L5, and it is more prone for injuries. It's the most vulnerable part, and it occurs even in the children and also in the adults. And this lumbar vertebral slippage, that is called as spondylolisthesis, without pars interarticularis defect. You can see in the X-ray image which is shown in the slide, that is in the red line, in the red arrow, you can see there is a small gap in this particular bone. You can compare with the first two picture along with that X-ray image, where the pars interarticularis has a small crack. So that we call it as a fracture. If this fracture occurs because of the osteoarthritis, that is, and it's called as stress fracture. And stress fracture of pars interarticularis without lumbar slippage without pars interarticularis defect, then we call it as a pseudo spondylolisthesis. So that is a new word. Every time when we read reports, we get a new terminologies. In the same way, you can get still more terms. Most of the points I have covered here. There will be still more points here. So this we may not be studying in the in anatomy or even in the surgery of or even spine diseases also we miss this one. But when we are interpreting this one, so it gives an exact diagnostic terminology. That is, if the spondylolisthesis is there along with the uh, damage to pars interarticularis, then we call it as it is a spondylolisthesis, absolute case. But when it is not there, when that fracture is not there, and then we call it as a pseudo spondylolisthesis. Okay. Then, and one more word we have seen is a vacuum phenomena. So this is very clinically helpful. See, vacuum phenomena involves in a in intervertebral disc, there will be accumulation of gas. This is quite shocking or astonishing how it can be accumulated, and we know in our science it is clearly explained that the diseases, that is Majjavrita Vata, which may be there, Astigata Vata, these Gata Vata Lakshanas will be present here. And this accumulation of gas with the disc. Why it happens? Because there is no fluid. Instead, that vacuum is created inside the intervertebral disc. So this is extreme degenerative conditions. So I have shown in the picture, that is in arrow mark, you can see the black uh, or dark lines are there in the intervertebral disc. Usually intervertebral discs are not that much dark, because when it is filled with the air, then only we'll get this dark shadow. Okay, so these are called as, and when you look even the x-ray also, intervertebral disc will have a black lines. So this will say about the vacuum phenomena. Vacuum phenomena means the complete degeneration of the intervertebral disc has created a vacuum inside the intervertebral disc, and there is air, and this air or accumulation of gas, we call it as a vacuum phenomenon. So without a second thought, this condition is an extremely degenerative conditions. One more point which is quite interesting, that is a Shamol's notes. I told in the disc stages of disc prolapse, there is a disc herniation and disc sequestration. See, when a disc sequestration occurs, the annulus fibrosus is broken, the nucleus pulposus comes out, and it is going to this the oozing of nucleus pulposus is there. This is a stage of sequestration. But where it goes, once it is displaced from its position, it gets deposited in the adjacent vertebral bodies. So you can see in the first um, picture, there is the blue color is a nucleus pulposus which is coming out, and it is getting deposited or getting an encroachment into the vertebral body. It may be a superior vertebral body or an inferior vertebral body. There is no any rule like that, but most of the times it will be entering into the superior vertebral bodies, and this encroachment forms over a time period, it forms a calcification, and we call it, and it looks like a nodes, but it is not completely filled with the bony tissues. It is a kind of cystic lesions will be present, and hence there will be a filling defect. You can see in the next picture, there is a small area where there is a filling defect. That bony appearance is not there. Instead, there is some dark spot is present. If a patient is having, even this can be identified in the lateral view of X-ray, and if a patient is having extreme stages of disc herniations, and it is a disc sequestration has already happened. For example, this happens in all the patients who are having a chronic history, and when you see the X-ray of them, you can see some kind of nodes or spots, black spots on the adjacent vertebral bodies. So that's suspicious of, and it is suspicious of the Shamol's nodes. And this is nothing to fear or nothing to worry. These are all not malignant conditions. Instead, these are all the contents of intervertebral disc, that is nucleus pulposum, is getting or encroached or embedded in the superior end plate or inferior end plate of the adjacent vertebrae. So that is a mechanism which is happening. So when you see shamol nodes in the reports, um, we'll feel that yes, the condition is quite severe. The prognosis rate is comparatively less. Okay, so it says for the patient is getting relief in 10 days. For other patients whom you have treated, they may be getting a relief in 10 days, but this patient will not get a relief even after 20 days, 30 days of treatments, because there is a anatomical changes has been occurred, and the degenerative condition has extended to its maximum level, and there is complete loss of congruity, compactness of this intervertebral disc. So we have to look into this point when we are interpreting the reports with Shamol's notes. Next point is a thecal sac indentation. First, concentrate on the first middle picture, where is a normal central canal. So this central canal is a path where the spinal cord is passing, and in the sides, on the left side, you have in the picture, the left side you have all the intervertebral disc along with the spine. See, the canal is not having any disturbance. It is uniform from above downwards, and hence this we call it as a normal. You can compare this with the first and the third picture. That is in L4 and L5 level, L3, L4, L5 level, and partial in the L2 level also. There is slight disc is slightly the disc is piercing, or it is causing a kind of pressure to the spinal cord. So this thecal sac is a membranous sheath or outer covering of the spinal cord, and when it is pinched or getting pressured by the intervertebral disc, we call it as thecal sac indentation. In the third picture, you can see the normal spinal canal or the central canal is being narrowed. This condition we call it as spinal canal stenosis because of displaced intervertebral discs. So this is also a term we get in the reports. So you can see, you can read this complete report. Desiccation changes with diffuse disc bulge causing thecal sac indentation and impingement of bilateral traversing nerve roots at L4 and L5 level. So thecal sac indentation is having a direct relation with the traversing nerve roots, and which is a level he is telling it is L4 and L5 level. So this is about the outer covering of spinal cord, which is getting pressured, or which is getting a kind of force exerted by the intervertebral disc, and hence it shows its symptoms. It shows the symptoms like in which level it is showing the indentation, and according to that level the nerve roots are showing, or the dermatomes are showing the symptoms. So this point we have to remember, in which level it is causing the thecal sac indentation, so that we can examine the dermatomes accordingly, and then we can decide which nerve is damaged. So this clinically we can identify. Next is a few rare conditions what we get in the MRI reports. That is a lumbarization, and lumbarization means it's a we call it as lumbarization or transitional vertebra. Both are same. These terms are given as a synonyms. Lumbarization of S1 and transitional vertebrae, it is both are same. So lumbarization means S1, that is say first sacral bone is not in the joint, or it is a combination with the S2, S3, S4 and S5. Instead, it looks like a LC, the lumbar vertebrae. And when you count from the anatomical landmarks, you can see that in the X-ray we have showed it is L2, L4 and, but we are getting one more count, that is L6. Means this first sacral segment is loose and it is away from the other sacral segments, and this separate sacral segment is behaving like a lumbar vertebrae, and this we call it as lumbarization. Most of the conditions, this is observed in young females or the adults within the age of 25 years, because a kind of we'll think about a functional low back ache will be there in school going or college going students. So this is not because of functional. This is a There is an anatomical defect which is already present in that patient. Some point it will trigger based on their lifestyle and working habits, and here we have to remember there is no any much of the benefits will be given to the patients. I'll advising of physiotherapy or some exercises to them to keep them calm, and these structures are flexible so that the movements will not be hampered to some extent. Stiffness may not happen, and otherwise you have to convince them this kind of problems can on and off repeat on and off based on your activity, based on your maintenance of postures and all. So these informations you can convey to the patient. Another such similar condition is rarely accidentally diagnosed is a vertebral hemangioma. Young patients will come to you and you will examine all SLR, femoral nerve tests and all. Nothing will be positive here. But patient has a severe low back pain and he or she will locate the pain. So that locating the pain in the vertebral bodies will be giving a suspicious that there may be something related to the vertebral body other than the intervertebral disc, because whenever all these tests will be done, whenever there is a and they'll be positive whenever there is a intervertebral disc bulge or prolapse. But here there will not be anything related to the disc intervertebral disc. It is related to the vertebral body. So vertebral body will become rich with capillaries, and because of this the vertebral body loses its stability, and hence it shows a kind of discomfort and the unequal distribution of body weight, or the patient is going to get stress and strain when they indulge in activities, like it may be in a sports or something related to the dance and all. These will be experienced by them during those moments. So when you take an x-ray, we can see a irregular fillings are there over the vertebral body. It may not look alike with the other vertebral bodies. It is more something related to the fluid filled structures, and hence it shows a darker spots on its surfaces. And one of the complications what we have to tell to the patient is, fine, we don't have much scope in allopathy system also. They'll go for some laser therapy and all. And one information what we have to give is not to indulge in any aggressive activities, because the only complication happens or this condition becomes clinically evident when there is a rupture of this capillary beds. So this information has to be given to the patient, and because of that, if the hemangioma is growing over a period, the collapse of vertebral body can happen, and the patient can end up in pathological fractures. So this takes quite a number of years. So it's our duty to convey them and observe the patient by repeated scans or MRI screenings once in a year. And clinically, what I observed is in these patients, we have to club the treatment of Vata Rakta along with the Vata Vyadhi Chikitsa. So, because the main dosha involved or dhatu involved is a Rakta here. So, we have to adopt or we have to supplement our prescriptions with the drugs related to the Vata Rakta Chikitsa. So, that's also important. And what I feel is Kashura Gulu works better compared to other medicines here. I had treated near 3 or 4 patients related to vertebral hemangioma, And in all the patients, the pain rate of pain relief is quite less. But when we are prescribing or when we are keeping the medicines like Manjishtadi Kashaya and Kaishwara Bukulu, which is mainly we are included under Vata Rakta Chikitsa and all. So Pitta Hara Dravyas, and the patient will show some kind of good response. Okay, one girl was there, and she was almost the symptoms were reduced in over a time period, but it is most disturbing to her even now. Next, one more similar presentation like sacralization, like lumbarization is sacralization. Sacralization is a congenital anomaly, or it may be a developmental like osteoarthritic also. So where in the picture you can see the transverse process of L5 is coming and joining with the ala of sacrum. So that's why the L5 will be tried to fuse with the S1. So this condition is unilateral and also bilateral. And in reports we'll get unilateral sacralization or bilateral sacralization. You can see this is a report which is saying about transitional vertebrae is present at L5 and S1 with the sacralized L5. So this is a one important a report which we got, and the word is not given as a lumbarization, it's given as a transitional vertebrae. Now sacralization, I have told there is two parts, means two conditions. Either it may be a unilateral sacralization or bilateral. So this was a case where bilateral sacralization of L5 vertebrae is there, and uh, reduced L5 and S1 intervertebral disc height, and even spinal canal also anterior posterior diameter is also reduced. So this all says that patient is having a symptom which is similar to a compression. Okay, nerve compression symptoms will be present because of sacralization, and also the flexibility of spine decreases once it is a sacralization. The mobility grade will be decreasing here. Next, the last clinical point which we have to remember when we are treating a patient of low backache, that is about the Cauda equina syndrome. We know the terminal part of spinal cord, we call it as Cauda equina. When the intervertebral disc diseases completely obstructs the Cauda equina, that is lower end of the spinal cord, then we call it as Cauda equina compression. So we will be treating a patient of low backache, but over one fine day, suddenly because of any minor trauma or minor jerky movements, the patient will feel a severe pain, numbness of the lower limbs. But along with these symptoms, he will have either loss of bladder and bowel control also. So when the issues related to the bladder or bowel is present, then we have to think about whether the patient is going towards the Cauda equina syndrome. So this has to be intervened at the earliest, so that otherwise both the legs of the patient may get paralyzed. That's why once the low backache patient complains of kind of perineal numbness or loss of bowel or bladder control, we have to immediately go for an MRI, and we have to decide what is the status of his disease, and we need to plan it at the earliest. We have to refer to a neurologist or an orthopedician at the earliest, because that condition should not be delayed. Once the nerve damage occurs, the reversal rate will be quite less, and that's why the patient has to be treated at the earliest or referred at the earliest in this stage. So this is a alarming. Next are the few alarming symptoms. What are the alarming symptoms we have to think, or we have to analyze when we are getting such reports? So this is a case where the patient had kind of dorsal stiffness is also there. It was similar, looking like Amavata Lakshanas, or we even suspected the ankylosing spondylitis, but the patient had a schwannoma. The differential diagnosis in the first MRI report itself, they showed about the schwannoma, but we sent this patient for the higher tests, and even in that also the patient was diagnosed and he was operated immediately, and the prognosis, from the bad prognosis it has come to the good prognosis. So these are the alarming symptoms where we have to act at the earliest, and we need to address the problem immediately. The chief complaint has to be addressed at the earliest. Next, there are some incidental findings. This incidental findings means we will do MRI for something else, and low back ache, and the patient will be having a pain which is radiating to the bilateral hip joints or the unilateral hip regions. So incidentally, the patient will be having some pathologies related to the hip joint. So that's why when the patient is examined for low back ache, if the test like SLR is negative or SLR positive, whatever may be the clinical findings, we have to, it's our duty to examine the nearby structures also. Because patient may say about the leg pain, but he may not say that where is its origin. He may not be knowing to tell that it is originating from the spine, or he may be ignorant to tell that it is originating from the uh, hip joints. So these points has to be made clear, and we need to send the patient for the MRIs. If you are writing, if patient comes to you with the, something MRI reports previously done, even low back ache pain patients means, don't ignore the patient, but you need to examine once again along with these MRI reports. And most of the times, the MRI report and clinical findings should match. If it is not matching, there is some problems. I mean, there is an issue related to the diagnosis. We might have missed another structure or a neighboring structure which is causing the trouble to the patient. So this was also a case. He had taken MRI, whole MRI screening, everything, and they didn't find anything. Means I think they have taken X-ray and all, and they didn't find anything related to the lumbar spine, and there is no any issues. Only sacralized L5 was seen. It is now also not much evident. It can be easily identified, but the patient is having avascular necrosis of the femoral head. That is stage 2. If you refer the stages of avascular necrosis of femoral head, we get nearly FICAT stage 4 based on the surface of femoral head that this particular category is done. And in this, all the tests are similar to that of low back pain. Means SLR will be positive to the patient on the affected side. So we need to examine the internal rotation and external rotation of hip joint. That we should not miss when we are doing this SLR test. So this will suggest there is a pathology related to the hip joint also. And you have to observe the attitude of the legs, bilateral foot also. Some conditions will be there where the fracture or dislocation of hip joint, subluxations also can give you a diagnosis. So these incidental findings also will be there. So you need to concentrate on them also. Next is some extra care where we have to take. So as I told, there is the one case I explained that the schwannoma was there. It is a kind of pre-malignant or malignant conditions only. And ankylosing spondylitis, we have to see from how many years he is suffering, whether only spine is involved or any other joints like sacroiliac joints are involved, or even the upper limb joints, everything is involved or not. So all these examinations we have to perform. That is a need of an extra care. So bone cyst, schwannoma and all, or telangiectasic osteosarcoma. These are the conditions which is going towards the malignancy. This is going towards the malignancy. So the patient will have a doubt whether this is a malignancy or not, and we may not be able to analyze those conditions. We cannot decide. At times, we may not be able to decide what to treat. So better to go for a second opinion in such cases, to you with your seniors or with the experts who are related to that particular subject. And in other cases, if we are finding it is unusual than the normal, what we have already discussed, like pot spine and all, that is a secondary to tuberculosis. In this, we need to give an extra care and also second opinion. Both the treatment should go hand in hand. That's why these are the points we have to keep in our mind uh, before coming to an conclusion. So this is a case of ankylosing spondylitis. You can see a healthy spine is that there is an inflammation in the intervertebral disc. Over a time, this intervertebral disc is getting fused. So that's why the X-ray looks like a straight uh, and it is like bamboo. It is also called as a bamboo spine with the central ridges. And at the thoracic levels, the vertebral body, it looks like a square. It is also called as squaring of vertebrae. And you can see that almost all are like uniform, a stick-like appearance is present. This is about the ankylosing spondylitis. And you know that once you are suspecting this, you have to go for a HLA B27 marker studies and all. So that goes when we start intervening with the disease. So I told the need of advanced imaging techniques. So I told that previously there should be extra care has to be taken for some kind of conditions. So this was a case where there is confusion. Even now the diagnosis is not finalized. What exactly is a reason why patient is getting a low back pain and all. So we have to depend on some repeated uh, imaging techniques and repeating or advanced techniques like PET scans and all. We have to depend on all those. And before coming to a conclusion, don't take up such cases. If you are not so confident, then we need to um, reconfirm 2 or 3 times about these diseases and start the treatment after that. If the patient is convinced with your treatment, fine, that's fine. But provided you have to remember that the repeating of MRI, don't think it as a burden. Instead, it should be explained to a patient in a positive way. We need to observe its prognosis. We have to understand the changes which is happening there, and so that we can plan the better treatment. So these informations you have to give to the patient. So that was the end of the clinical cases. So after knowing all these points, the overview of this presentation is we can apply all the treatment modalities told in Vatavyadi Chikitsa, no doubt in that. But our principle always depends on the three doshas. So we need to understand which dosha is pradhana, whether it is vata pradhana vyadi itself or vata madhyama vyadi or vata is in a adhama state. That is tarathama bhavas, which is the most prevalent dosha, which is the second most, which is the third most. In this manner, we have to analyze the signs and symptoms. Then we can plan our prescription or treatment principles. Okay. Next, what is other benefits? When you are analyzing these reports in a right way, there is a lot of scope for treatment. Because um, don't get panic or don't get confused whether we'll be doing right or not. Read the report 2 or 3 times and analyze it. Where is the damaged mechanism? How far we can correct it? What is the scope of our treatment? What is the limitation of our treatment? What is the integrated approach that we have to consider from the other system of medicines? So this overview we can understand when we are interpreting the reports in a quite logical way. And most important, and no need to be shy about that, it is limitations. We have to be very open with our limitations, and when we draw conclusions out of these reports, we can understand this is our limitation, this is my scope, and here I need a help of other person, or here I can help the other person also, other person in the sense whatever the other treatments he is taking. So this kind of healthy approach is very much essential, and it will be achieved only when you interpret these reports based on our principles, which are explained in our science. Because at the end of the day, we are going to prescribe our own medications, and if you are following some treatments like panchakarma treatments or any other therapies, even rakta mokshana, the basic principle remains on the basis of doshas. So never forget that dosha analysis, but the scientific terminologies which is given in the report will give an overview of the disease pathology which is happening in that particular person. And the last importance is you can boldly explain the patient related to the prognosis. There will not be a single drop of uh, inconvenience on your face telling that whether this condition can be managed or not managed, etc. Confidently, you will declare, or you will be you are informing the patient that this condition is possible to be treated to up to this level, and it is not possible to treat beyond this. This demarcation will be getting when we are interpreting these reports, understanding the mechanism as how it is, along with that, understanding them um, based on our treatment principles, because we need to apply our medicines, our therapies to these patients. So, this is very important. So, the prognosis of the disease can be confidently explained to the patient. So, that these are the five motto of presentations or interpretation of these reports. With this, I conclude my presentation. I hope I have given some insights on this topic. And if you really work on that, you can uh, get more informations related to this particular topic, and your approach to the disease becomes more focused, and your treatment becomes successful by taking a short span of time period. This is very important. Um, every time my teacher used to say that we have to give the treatment to the patient so that when he comes to the next visit, he should come up with maximum relief of symptoms. So this will be achieved only when we are approaching the disease, when we are in a particular way, when we are addressing the problem in a quite different way. Exactly, that is also needed. Or when we are prescribing some, or when we are indicating specific investigation procedures. So all these will be in total giving a kind of best relief to the patient. So everyone's target, every doctor will feel happy when a patient comes to us after a week and say about the maximum relief of symptoms. So this can be achieved. Never think that our science doesn't have acute medicines. We have lots of acute medicines. Only problem is we are unable to locate the issues, and we are unable to locate the pathological conditions, and hence when we prescribe the disease medicines, that disease stage might not have happened, or it might have crossed. This is a technical issues what we are facing right now. So when we focus the disease diagnosis or understanding of pathology with variety of the available resources, then the diagnosis will becomes more clear, and once the diagnosis is clear, the treatment becomes more effective. And I hope you'll all follow my this presentation and try to adopt in your clinical practice. With this, I conclude. Thank you. Thank you for the opportunity. And if questions are there, most welcome. I'll try to answer all of your queries.
Thank you, ma'am. Definitely, it was very insightful. And we will go ahead and take some time for questions now. Here, uh, looks like we have a few questions already.
Okay.
Mm, Ambika has this question. What are the symptoms of cervical lordosis and straightening of spine?
Just a second. Okay. See, the patient's complaints will be pain, stiffness of the neck, and also even if it is a lumbar region, stiffness in the low back region. That whatever you coin test you perform, it is not possible. If it is in a cervical region, then person will not be having um, this the restricted range of movements. So this is a common symptoms which are exhibited to the patient.
Thank you, ma'am. The next question is bulging of disc is due to which dosha? It's from Dr. Girish.
See, the bulging of disc is not, you should not interpret in such a way. Uh, see, what is the cause for disc bulge, you have to analyze. So when we are analyzing the cause for the disc bulge, it always becomes with the, if you are taking it from the orthopedic text, it may be a trauma or degenerative changes. But this cause will be having a point, and you can rightly declare the etiology once you interrogate with the patient. You have to list out what are his lifestyle habits, how he is taking food, what is his work pattern, sleep patterns, everything you need to take. And in acute traumatic cases, everything doesn't apply there only. It is majority it is because of acute injuries. No need to go and assess about the doshas there, because sudden jerky movements or unequal distribution of weight has happened, and the threshold or the pain threshold or the protective threshold of the intervertebral disc is being disturbed suddenly because of that movement, and because of that pressure the annulus fibrosus ruptures. That is a mechanism which happens in case of um, traumatic causes. Whereas in degenerative causes, you need to list out based on the patient's interrogation. That is, history taking becomes the most important point to interpret and to understand along with your reports. Both should match. That's why.
Okay, thank you. The next question is, can we treat schwannoma with Amavata principles? It's from Dr. Gauri.
Yeah, this is uh, most of the uh, doctors will try to correlate like that, but I don't feel like it is to be treated with the principles of schwannoma, because we need to protect his lower limb. We don't know when the what, acute stage happens. So it is quite risky to apply all those. After the treatment, we have seen one of our senior faculties here used to treat these cases, and patient will regain his normal activities over a time. But at the time, I don't prefer to take risk, because it's related to the patient's life. That's why. And better he can go and rule out what is the cause and what is the level of compression and all. Then he can get the surgery done. Then, after that, he can come to our treatment if wishes. Otherwise, better to get good care of treatment from higher centers will be the treatment option.
Okay, thank you, ma'am.
Thank you.
Another question from Dr. Priya. Can we manage scoliosis condition and how is it managed?
Yeah, that's what I have explained. When the curvature is a S-shaped and the lateral deviation, that is left deviation or right deviation, is slightly present. It is in few millimeters to centimeters. And if you are examining the patients from the C5, that is occiput to the sacroiliac joint, that is sacral part, sacral promontory, at that region, if you are keeping a tape, then it should lie in a single plane. It's a single line. So this is a clinical examination we'll do. What is the centimeter of deviation is present? Based on that, we can plan the treatment. Usually in a smaller left deviation or right deviations, we can give some pain relieving medicines also. And exercise and physiotherapy, special exercises and massages will be helping here. Apart from that, um, patient lifestyle, that is how he sits, how he moves, and how he is driving, how he is working in front of a system, that is computer. All these will has to be considered here. And in a severe, that is a C-shape formation of the curvature, here we have to go for some fixations. Our treatment may not be happening there because that curvature is too much convexity is there. Then the patient can go for a pathological fractures or compressions over the viscera. Everything is there. That's why it's better to go for a surgical corrections. So there is a technique where they'll manage this kind of conditions. In early stages, in a very small deviations, we can treat. Physiotherapist will play a major role. We need his help. Yeah.
Thank you, ma'am. Next question is from Ambika again. She has any findings for sciatica syndrome, maybe she meant syndrome, in MRI scans.
Sciatica, that you have to examine sciatica symptoms. They won't say about any kind of directly, they won't say about sciatica. You have to, based on the nerve roots, you have to identify, and also based on the clinical examinations and intervertebral, that levels of intervertebral disc damage I told, no, L3 L4 levels or L1 L2 level. Based on that, we need to interpret that for sciatica. So like a diagnosis, they won't give it as a sciatica.
Okay, ma'am. Another question. What could be the management of decomposition of lumbar disc in Ayurveda?
It is quite tough, and I told the disc. It is not decomposition; it is a sequestration. It's like it is decompression. Something they are telling. It's
Yeah, she meant decompression of lumbar disc.
decompression is not, compression is there, and that is a compression of narrow root. Decompression, a word is not so much appropriate. And in sequestration, that is once the disc is completely lost in its texture, the discectomy is one surgical procedure. They'll go for that, and they'll be putting a prosthesis, that is intervertebral disc prosthesis. That is what it's not a natural, something made like a joint replacement. In the same way, they'll do these surgeries. But in Ayurveda, actually, it is quite tough. Patient will be, if it is compressing the nerve roots, he'll have or she will have a severe pain. Whatever the treatment you give, the treatment pain may not reduce. And if pain is there, but numbness is also there along with that, means it is quite tough to manage. If it is a stage of sequestration, if it is in a disc bulge, numbness is there, means not to worry, we can give our treatments, no doubt in that. And if it is in a sequestration, then it is quite the prognosis may be less, prognosis rate will be low.
Okay, thank you, ma'am. If there are any more doubts, please come up in the chat box. Looks like we have covered all the questions, ma'am.
Okay, thank you.
Thank you.
Rajeshwari, madam.
Yes, sir.
Yeah, it was real need of the hour for all of our students. Like
Okay.
you have opened so much of diagnostic ways to interpret all various MRI reports and the anatomical insights of the same.
Okay.
So we are really grateful to you, and it was such a wonderful, detailed, elaborative, descriptive, knowledgeable session. I really enjoyed it. I was completely on your talk, and the interpretations were really nice. Thank you so much for all this, all the good presentation what you have done today. So really, our students, I hope everybody are benefited and they'll apply all those things what are being taught by you today in their clinical practice, and they'll come up with good Ayurveda treatment for various disorders. Thank you so much. So on behalf of our college, department and principal and all the staff from Shalyatantra department and all these scholars who have joined us today, I'd like to extend a very warm thanks to you Okay, I think there are some more doubts, madam. You can clarify that. Archana, can you go ahead with that, please?
There are no more doubts, sir. All the students are thanking ma'am for her
Yeah.
session.
Then, yeah. Thank you so much, ma'am. Thank you so much, Rajeshwari.
Thank you,
Yeah,
sir. Thank you. It's my privilege because it's my home institute. This is the second
yeah.
time. Okay. I'm very
Actually,
happy.
we wanted to have your session quite long back, but due to some these all these COVID and our hospital is being converted into COVID care center now. So
Yeah,
because
yeah.
of some reasons, we could not able to do that. But it was great. Like today we had you, and all our students have benefited. Thank you so
Thank you,
much.
sir. Thank you, sir. Thank you, sir. It's my pleasure.
Thank you. So
Thank
Archana,
you all.
shall we
Thank you, sir.
end this today?
Yes, sir. We'll be concluding.
Thank you.
Thank
Thank you,
you, sir.
Rajeshwari. I'll call you.
Thank you, sir.
Thank you all participants.